conversations that involve healthcare violence and issues that get your heart rate up. Today, I have a special friend that came with us, Dr. Proffitt, Tiffany. Let her introduce herself.
Hi, I'm Tiffany Proffitt. I'm board certified emergency medicine practicing in Arizona with my amazing charge nurse, Holly.
And we have been going back and forth, I feel, probably for a month now, even
Mm-hmm.
before recent incidents of the issues of healthcare violence and how just kind of unsupported, unrecognized. It's just kind of like a muted conversation that almost feels taboo. Like we're not supposed to talk about it because I don't know if it's people are worried because of HIPAA or whatever, but I'm like, someone needs to say something and we need to get our thoughts and feelings out there because they're valid. And it's a huge issue that's going on across the country, as we've seen in the news
Yeah.
recently.
Even just today on one of the ER Facebook pages, they talked about another incident in another ER in Michigan. So it's omnipresent, it's more and more frequent, and it's true. It's something that I don't know whether they just don't want to accept that this dirty kind of dark side of medicine exists because it does make people feel uncomfortable when we're seeing violence escalate everywhere else to live in this kind of naivete world that it doesn't exist in healthcare just needs to be dispelled.
Yeah. And that we just kind of have to tolerate it, that we get comments like, oh, it's just part of the job, or you could have done something differently. And it's our job to keep the patient safe at all times. Well, what happens when they're not keeping us safe? We
Hmm.
didn't sign up for this. I know in nursing school, I wasn't trained on how to handle violent patients. We were kind of like low key warned and get this was like a decade ago. And I know things have changed since COVID and gotten a million times worse, but it's just almost it's just unsafe at this point for everyone involved.
Oh, absolutely. In medical school, the most we heard about violence in medicine was nothing.
Oh,
Let's just be
no.
honest, nothing. You were taught the science, you were taught the clinical part. There was no discussion of patients being violent. There was no discussion of threats to your own health and safety. And then as you go through kind of your clerkship years, you maybe see a bit of it. And then in residency, it's all of a sudden, well, what are you going to do?
Yeah.
What are you going to do with this patient who's screaming at you, who's threatening your life, who's swearing at you, who's spitting at you, who's trying to hit you?
Yeah.
And you are left to figure it out because unfortunately, usually the attending doesn't want to be anywhere near it. And so as the resident, that's your responsibility.
I'm sure they just kind of sit back and they're like, I wonder what they're going to do.
Mm-hmm.
And how does that conversation go if you're like, I don't know what to do? Were you ever in a situation where you felt uncomfortable? I'm sure, but that you were like, I literally don't know what to do in this time period to keep myself, but also the nurses and the techs and security safe. Like someone has to do something. And you're like, oh crap, that's me.
And it's very true. And I remember early on, because where I trained was in a very violent area. There was a lot of gang violence, a lot of drug war violence that went on, a lot of non-accidental trauma. And so it was very much the first time I had a violent patient. First off, the attending was frustrated that I allowed the patient to escalate. Somehow I had failed
Mm-hmm.
by not verbally de-escalating enough. And then when asking what I wanted to do, I looked at them and was like, well, what can I do?
Yeah.
And they
What's
said, well,
allowed?
yeah, what's allowed? And that's the big thing is what's allowed. And that is still a big gray area that we face today, every day,
Mm-hmm.
despite everything that's going on.
Yeah, I feel that we kind of have trends of patients in the ER that we work in. I
Mm-hmm.
know you work in a few of them, but my specific ER, we have a large intoxicated population. I think there's 500 bars in like a 2 mile radius around us. So it's very lively on the weekends. It's lively every night of the week, let's be honest, but
Mm-hmm.
significantly more social issues going on the weekends when it's time to party. And coming from an ER that wasn't like that previously, it was kind of eye-opening. They're like, "Oh, just wait till Friday, Saturday nights." I'm like, "Oh, those are like dead nights. Like those are where I like was able to get my homework done through my master's program." And now we're literally lining the hallways with people that are drunk that we're now having to wrestle to get back into bed and tell them not to get up and to keep their clothes on and ignoring basically the people that have medical problems because these people are taking up all of our resources.
Mm-hmm. That's exactly right. And that's kind of the underlying challenge is that we become overwhelmed because the aggressive drunk patient, where if they were at the bar and they punch the bartender, usually gets brought to us in the ER. where we don't have the staff, especially at night when we both work, we don't have the resources to appropriately monitor them. So they get lined up in the hallway, and then we have our sicker patients in the beds, but we always get pulled away from the sicker patients to manage those social patients because inevitably, if they were causing problems and being aggressive, being physically violent outside the ER,
Mhm.
there's still that inside the ER. But now I don't have the cops.
Yeah.
My security guards are somewhere on the other side of the hospital managing an issue.
Yeah.
So it's my poor nurses, it's my techs, it's myself trying to manage this when this is not anything we were trained for.
No. And I think it's hard for us to know what the right thing to do in that situation is because for those that work in healthcare or don't work in healthcare, when you get an intoxicated patient come in, it's a social problem. It's not normally a medical problem unless they're actively going through detox and withdrawal, which is a whole nother story, which can be problems, but they're here for a reason. The people that come in that are intoxicated from just drinking too much at a bar, that suck up these resources. It's at what point do you like, okay, if we can just find you a ride home and you can walk a straight line and talk not really slurring that bad, we can get you out of here. But there are sometimes the ones that totally escalate and end up threatening our nursing staff, let me get the F out of here and disrupting our poor. I mean, think about who else is in the ER. I have to remind them. I'm like using my mom voice in the hallway, like, you cannot speak that way. Do not cuss at me again. There's children in the ER. There's your old grandma next door that just had someone pass away. It's like they're just totally mindless of like situational awareness on what's going on around them. And not only, like we were saying, is it disruptive to where we allocate our resources, we're probably short staffed because that's kind of been life lately. And you're it's just not fair. It's not safe. And it's almost out of control.
It is out of control. And I love that you bring up the other patients in the department because I've definitely had one night, probably working with you. Um,
We've had some fun nights.
we've had some fun nights together. But it was an intoxicated, kind of middle-aged woman who was actually a lawyer. She's a lawyer. She's an
Oh,
educated, productive woman. I know you're like, I remember her.
I'm like, ooh.
I know. And completely out of control. We needed 5 people to hold her down just to try to get any sort of access to try to give her medication to calm her down or anything just to keep her in the bed. And we had these sweet little twins next door who had both strep and the flu.
Oh God.
And and our poor tech was trying. He's like, "There's children in the department. Can you please keep your voice down?" And she is swearing
Yeah.
and screaming and kicking, and she yells at the top of her voice, "F the children!"
I remember this, and all the staff was just like, we hope that they didn't hear that. It's out of control.
It's absolutely out of control. And then, like you said, it gets to the challenge of what can we use to restrain them?
Yeah.
Well, clearly in that instance, verbal de-escalation is not going to work.
No.
She's already at a 20. She's
And
already
probably
at it.
threatening that she's a lawyer and she's going to sue us and don't put
Mhm.
our hands on her,
Mhm.
which you're like, what do we do?
Yes, if you're punching everybody and you're causing a problem in the emergency department and you're clearly not safe to go home,
Yeah.
and that's the other issue. If they're so intoxicated, we know they cannot make safe choices.
Mhm.
They cannot safely get themselves home. We have to monitor we have to monitor them until they are either sober enough to go,
Yeah.
or we can find someone who is sober enough to care for them, which usually you can't in those
Yeah.
patients
Most
most
of
of
the
the
time they
time.
hang out until we can wake them up at 5 or 6 a.m. and we're like, okay, we charged your phone for you. And they're like, oh, thank you.
Exactly. But then I look at this patient and I can sedate them, but how much worse is their mental status going to get?
Yeah.
Are they going to be so depressed from a respiratory rate, which then we have to monitor for, where I'm going to be on the verge of needing to do something really aggressive, like intubate them and take up an ICU bed?
Yeah.
Um,
If there is ICU beds.
yes, if there's an ICU bed. Or does that mean that they're going to be knocked out for potentially 20 hours, which means that I need to take up an inpatient bed? So all of my boarding patients who are waiting for a bed
Get
are going to
bumped
be
down.
bumped
Mhm.
for this one.
Yeah. Not to mention the nursing resources. You have to restrain a patient, and there's obviously the policies on that. So, just to clarify, I'm sure it's different in every ER, but danger to self, danger to others. If they're actually being aggressive, it counts as a violent restraint, which, from a nursing standpoint, we have to be in there taking vital signs, looking for injury, and checking pulses and the tightness of the restraints every 15 minutes. So imagine that you have only 2 or 3 nurses on a team, and this one patient that just couldn't handle their alcohol is taking up every 15 minutes. Your nurse is basically helpless at that point. They can't go help with anything else. They can maybe run to the bathroom, maybe run to get a grab of food to eat, and then you get reprimanded from leadership saying, "No, you didn't take a lunch that day." You're like, okay, we'll get on that different day.
Yeah.
But it's so many resources. Not only just like once they're down and restrained in bed, okay, cool. They're not fighting you anymore. But now you're having to go back in the room with the patient that was just threatening to hurt you or did hurt you. And you have to still care for them. And that's almost like a whole mental game where you have to just remove your feelings and strictly just do your job.
Mhm.
And unfortunately, that causes other problems with caring for other patients, but that can be a different subject.
Yeah.
But so again, once we restrain these patients, it takes up that many more resources. And then you have to coach the patient once they start coming to and they're like, untie me, untie me. We want to. We didn't want to do this in the first place. It is not fun for anybody. It is not safe for anybody. And then you have to be like, okay, I like talk to them like a child. I need you to tell me you're not going to swing and hit at my staff. And then I can get you out of these restraints. I need you to stop spitting at us or stop cussing and show me that you can handle your own.
Mhm.
So that way I can feel safe, kind of letting you have access to normal privileges of like daily living again. And
Mhm.
it's like a mind trick. Like you're literally talking to adults like children.
Oh,
And
absolutely.
it's like infantile at this point. And I swear my mom voice has gotten so much better. I talk to them almost like way worse than I ever would talk to my children because they're just not listening and they're
Mhm.
not able to be like brought back down.
Mhm. Yeah, they're very much grown adult size, like 250-pound toddlers
Yes.
who are intoxicated and fueled with whatever substances they may have taken,
Yes.
who are not rational, who are not safe, who are very aggressive. But there was no ramp up to this.
Yeah.
They came in that way.
Mhm.
And it is true, like you said, it's just funny that we have to sit with them for them as many hours as we do. Can you imagine if you went to McDonald's and you swore at and spit at one of the cashiers? Would you then be sorry, would those cashiers be forced to keep you at that McDonald's to watch you?
No. No,
No.
they'd be like, "Get the F out of here, and you are not welcome back. You are trespassed."
Exactly. And the cops would be called and they would be charged and they would not be allowed back.
And they would be brought to me.
Yes, they would be brought to us
Yes.
to solve the problem.
Yes.
Um, Anywhere else in the world, there's a safety net and there's security measures. And for whatever reason in healthcare, and especially in the ER where we work, and the dying come to us to come back to life. The dying come to us to not die.
Yeah.
The broken come to be fixed. And here we are, not safe, not protected, and forced to spend all of our resources and hours
Yeah.
caring for someone who could not make the responsible decision to care for themselves.
Yeah. And looping back to nursing school and how you explain medical school, we are not properly taught that this is a normal occurrence. I think it's eye opening, especially when we've got poor nursing students in the department and they're the sweetest little naive, like 20-year-old, like, I can't even drink yet. And I'm like, okay, you're staying out of this room. Like, one, I don't want you to get hurt. Not everyone has good intentions that we can prove because our experience,
Mm.
but it's just you're not taught how to care for it, how to handle it, and how to still treat them like a patient after they do that to you. Because that, like I said, is a whole mind game on
Mhm.
removing yourself and your feelings, which again is just almost a detriment in healthcare because it's creating anxiety and issues in patient care because you have that experience in the room next door. How are you supposed to go answer the call light to the room next to that patient and not bring in those frustration feelings or that trauma of, okay, that patient tried to hit me. So how do I know you're not going to try to hit me? And that reservation and that you're holding yourself back and you're not able to really show them the love and the caringness that you went to school to give to people. Because I think every nurse goes into nursing in order to do that. But I don't think once you actually become a nurse that any of that is supported because how society treats us.
Mhm.
And it's sad. That's why people are leaving healthcare.
It's true.
But I think that we totally touched base on intoxicated patients, some of the violence that we experienced just from that population alone, in that we both were not kind of up trained into how to handle it. And I think that there's more conversation around that. But thank you so much for touching base on that with me. I'm glad that we have like a like mind on what's going on. I know from our personal experiences together and, just a casual Friday night getting threatened
Yes.
and,
Yes.
threatened to be hit and murdered and they're going to wait for us outside the ER. I'm like, okay, honey. But yeah, thank you so much for coming on Tachocardia. I feel that I like, you should feel my heart rate right now. I'm just like pumped up. Like I got more stories to tell. Um, and that I know there's changes to be made. And I'm hoping that that is the kind of foundation of this podcast is just to bring to light these issues and know that it is safe to talk about it. We're not breaking HIPAA. I'm not naming organizations. I'm kind of calling all of them out at this point that something needs to be done and that I'm ready to tag team with to drive change and not just be like, this is a problem for someone else to handle, that there are solutions and that I think that we have great mindsets and a great team and there's people out there trying to drive legislation change and a whole lot more that's coming soon to make it safer for us so that way we can still continue to come to work and do our best and actually care for patients, which is what we all got into the profession in the first place to do.
That's why it's called healthcare.
Healthcare.
Yeah.
Yeah. But someone needs to care about us at the same time.
Absolutely.
Awesome. Well, thank you. That wraps
Yeah.
up our first episode of Tachocardia. Thank you for being here and more topics coming soon.
Yeah. Thanks for having me.
Thank
Excited.
you.